Yeah, we're ready. Go.
And we're live in 5, 3,
2,
1.
Well, good morning, everybody. My name is Jens Chapman, and welcome to this edition of the STED Talks. It's a distinct privilege to have you here Wednesday, February 21st. And STED, as you know, stands for Spine, Technology, Education, and the D is multidimensional. There's another D in there, discovery, discussion, debate. And we'll heavily emphasize debate today in a discursive fashion. Yet another D here. We have a great visiting professor today, Dr. Alexander Tapio Mameghani. Conflict of interest, I'll say later as I introduce him more formally. He comes from Munich as well, and he's going to talk about less invasive strategies to fuse the spine. He's now in the Kantonsspital Baden. For those who know the German language, Kantonsspital is a Swiss entity, so he's a well-known academic and practicing spine surgeon, and he's talking about less invasive strategies to fix the spine from the back using cortical screws. Corey and Ben are running the controls in the back, and is Dr. Mameghani live with us?
Yes.
Can we just have a visual and an auditory? Grüezi, Alex. Wie geht's?
Hello, good morning to you. Thank you very much for the invitation. Yes, I'm here. It's 3:30 in Switzerland. I'm happy to join, and thank you for this invitation.
So great to see you. You look good. And how's the weather in Switzerland? Do you have snow?
So no, in the mountains, yes, but here in the low field, no, I don't have snow. It is
Good.
2 weeks ago, yes.
So we'll introduce you formally later. We have, as always, a couple of cases, and we'd love to hear your thoughts on it. There are 4 cases. They all pertain to degenerative problems of the lumbar spine, so there are no curveballs there, okay? But they just show the multidimensionality of patient expectations, patient presentations, and what we can do. So there are 4 cases. And so that you don't feel too kind of taken aback, we have a German research fellow of ours, Dr. Julius Gerstmeier, who's going to show case number 1. So Julius.
Good morning, everybody. So also a brief welcome from me. My name is Julius Gerstmeier. I'm a research fellow here at Swedish, and I'd like to kick off today's session with a case. We have a 50-year-old female presented as a consultation with lower back pain and bilateral L5 radiculopathy. She has had this pain for about 5 years. It has worsened over time. She also presented with perianal discomfort, but showed intact bowel and bladder control. She had undergone some quite treatment, so she had physiotherapy, she had some injections, massages, and care, but over time this didn't succeed and it worsened over time. When we look at her history, she have a type 2 diabetes, a BMI of around 30, and depression. She never smoked but uses recreational drugs as in CBT patches. And she had some minor surgery with kidney stone removal and a pelvic floor restorations and a tonsillectomy in the past. Looking at her examinations, we'd see no motor deficit, but corresponding to her symptoms, we see a sensory deficit in the lower extremity for both sides. So looking at the images, we have the plane views on the left side and the extension and flexation on the right side. We have a end-stage degenerative disc spine disease in L5 and S1, and also a degenerative listhesis, myodine grad 2 in the segment L4-5. Completing those images with an X-ray and a CT scan. So this is a CT scan. You can see no fractures, advanced facet arthropathy, and also a bony stenosis of the L5 neuroforamen. We also have conducted an MRI scan. And then we have, as mentioned earlier, L4-5 bilateral facet arthropathy with a ligamentum flavum hypertrophy, disc bulging resulting in stenosis, and a severe degenerative disc disease L5S1 with advanced facet arthropathy and bilateral stenosis. So to sum things up, we have a 56-year-old female with low back pain and radiculopathy, intact bowel and bladder control, but perianal discomfort. The symptoms have been aggravating for over 5 years. We have failed non-surgical treatment. Her ODI score is at 46, indicating severe disability, and she has some risk factors to surgery. In imaging, we have an unstable degenerative spondylolisthesis, L4-5, with stenosis, and also an end-stage degenerative disc disease, and L5S1 with a bony femoral stenosis. So they would be, as you know, plentiful of treatment options. So this is what we did.
No, go back.
Oh, sorry.
Alex, go back to the last image. Oh, that's horrible. Never mind. So Julie says a nice presentation. Go back to one of the last images, like that X-ray maybe.
Yeah.
Alex, this is, I think you'll agree, something that you'll see, that we all see all the time. And by the way, I wanted to just shout out to Dr. Amer Aziz from Pakistan. So many friends, Dr. Yamamoto. And I see, obviously, Dr. Shimandal and many others, too many to spell out, but it's cool to have you all here. Thomas Riley, great to have you. So this is a widely, commonly present thing that we see nowadays. And this lady is a normal citizen, and she has done everything. She's not gone the opiate route, which until recently was very common in our country. But whatever you can think of, she's done, including some alternative medical therapies. So anything else we should have done, or you could have thought of, any wisdoms, and assuming that she's explored those too, maybe, what would you do surgically?
Yeah, Jens, I would answer a different way if you have asked me before the Scandinavian RCTs have been published. So I think this is the classic situation. I would have nothing else recommended than a fusion, at least for 5. You can discuss about including 5 as one. And I recommended this until like let's say 2015. And then with our partners from Scandinavia, from Norway, listen, this brilliant European Journal of Medicine RCT from Auspeval. They randomized the degen spondy into into decompression only, and compared to decompression and fusion, and found no significant difference. So I switched. It was not a paradigm change in my practice, but I switched to be less aggressive with the screws, and I would have decompressed anyway. I don't know whether the perianal sensations are really explained by the amount of recess stenosis, but I think she would benefit from a decompression. And then after having some cases of unhappy patient without fusion, I'm now not really smart enough to tell you what you have to do. There are still these 2 options, and I think due to this amount of difference between flexion, extension, or lying MRI examination and upright X-ray, I would tend to fuse L4-5 at least. And if you include L5 as one, I'm absolute agree with this.
This is a great discussion because, again, I actually, whenever we talk at international meetings, and I hope we'll see at the Global Spine Congress in Bangkok later this year, it's always amazing to me how we go parallel. I used to be far more aggressive with fusions, and I think the other cases we'll see today will show that But this case I followed for a while myself. I always try to get a feel for patients, and I did think that a fusion, Julius gave it away, so not much pretending around. No, it's okay. I thought the facet arthropathy at 4 or 5 was so significant. She had a positive facet fluid sign, so there's a big gap there. And for me, the open question for these 4 or 5 cases, if I decide to fuse them, is always if they have a bad 5-1 disc, do we include it or not in a fusion? Or do we build a fusion on top of a ongoing degenerative process that has not fused yet? So this is one of those things that I know we can spend all morning long. Why don't you go forward to show what we did and maybe use that as an example for how you would have done a fusion, because again, you're going to talk about cortical screws and less invasive techniques later. And I'm still a posterior midline surgeon. I try not to rip apart the spine. I try to be fairly smart about our incisions and do far less, but far more strategic soft tissue dissections. Do you have the post-op?
Yeah.
Okay. So I did a conventional open posterior midline surgery. And again, Julius reviewed the chart. So Julius, tell us how she did and how things are.
So just to give the example here, we did, as Dr. Chapman said, a posterior fusion with interbody cages and a decompression. Just to complete this, we also have a post-op CT scan I'd like to show. And in follow-up, she did pretty well. So her pain decreased. The overall ODI score improved a bit, but not to normal values. But she certainly did improve. She did have a pericarditis and not related to surgery during the follow-up period, which impaired her a little bit, but overall she's doing well.
So we just saw her in follow-up, and I just thought this is a conventional case. I use these sacral alar screws at the bottom just to augment S1. Is this an anachronistic approach towards surgery? Is this still okay nowadays as we have so many less invasive surgeons? Again, I think Yulia summed it up very well. She, I think she's 3 or 6 months out now, something like that. 3 months out. So she's returned to a better than before lifestyle. She's off all medications. She smiled. Her ODIs are better, but not what I would consider, quote, cured. She is very optimistic about the world. She is, again, living, working. She had a medical setback with a weird pericarditis, which may or may not be immunization related. We won't know that. But is this an anachronistic way to approach this now? Is there a clear difference in your perspective to do less invasive strategies, but maybe accept less of an alignment improvement?
So, Jens, the question about MIS is always who really benefits the most. And I think when you look at 56-year-old patients, we can summarize this group of the mid-50s as young patients compared to the vast majority who is above 70 years. So the 75, the 83-year-old patient, this is our average age. And I think when you do a lot of surgery, you have got parameters, you find differences where MIS solutions are superior, like blood loss, like OR time, because you are doing the good old posterolateral fusion as well. I've seen grafting on the posterolateral side of the rods as well. So I was taught this way too. So Bernard Jeanneret always performed posterolateral, and he did not do so many interbodies because it was a different time when he practiced. And the PLIF cages, yes, they're a little bit old-fashioned here. So we are always using the oblique or the banana cages, the steerable or the straight, not the bilateral. Maybe this is because it's a little bit faster, only do it unilateral. I think in the end, it's up to low doses, it's up to fusion rate, it's up to the amount of decompression. Don't make compromises. And I think anachronistic is not the right term. I love these images still because you can identify principles in spine surgery, and we should stick onto principles and not to implants and something like this.
You're a very wise speaker. I'll ask my partner, Amir Abdul-Jabbar. Amir, what would you have done? You're a young generation guy. You're like Dr. Mameghani. Would you have done a posterior midline? Would you have, I know you do OLIFs, you do anterior procedures. What would you have done, Amir?
Good morning. I think this is one of those cases that I as you mentioned, it's a very common pathology. There are, some people who really feel pretty strongly about a more definitive surgery, and in that case, I would try to push them towards a fusion. Doing, I think anterior, posterior approaches, I think all work well in the appropriate hands. But I do also think that decompression only is an appropriate approach if, the patient understands that it may not give them, complete relief, or, they may end up with a fusion down the road. If you can save them a more invasive surgery, I think there is a percentage of patients who do well with decompression only. And as long as you have that conversation with them, I think that, this kind of degenerative spondylolisthesis is just so common. And, you really have to cater the approach to the patient's lifestyle and their goals.
Great. Now for something different, great commentaries both. Neil Patel is one of our great neurosurgery spine fellows, and he's from Penn State. And he has a different angle of one of the 4 cases. And by the way, we have so many great visitors here today, and any of you who want to communicate, I'm in the chat room, so please fire away with criticisms, commentaries, suggestions, or simple queries. Neil.
All right,
what
so
you got?
I have a case, 68-year-old. 68-year-old gentleman who presented to an outside surgeon with radiculopathy, L5, left greater than right. He had tried some conservative measures and treatments, and his ability to walk had been limited because of his pain. I just have kind of a quick CT of his abdomen, just for reference, for his BMI of 37. His A1C was 6.2, and he didn't have any deficits in terms of strength per se when he was seen at outside hospital. These are his pre-op images, so 5 years ago and now, and overall no new kind of listhesis, spondy in terms of dynamic, etc. He did get an MRI. And I want to point out facet fluid at L5S1, significant amount on both sides, with the disc bulge with compression of nerve roots bilaterally. And no other overall kind of significant issues. Otherwise, has some cysts in his kidneys, nothing significant.
Do you have parasagittal views, Neil? Yeah, you're going to scroll through that in a second. Yeah. So no central stenosis, just like the last patient.
Right there.
And here's the 5-1 foramen. And so the squashed root on the right side. So squashed L5 root.
Yep.
A compromised left L5 root.
Compromised left, yep.
And no central stenosis. And weird dysplastic end plates. So again, question to you, Alex, what would you do? So this is, oh yeah, sorry, we have a CT also. These are all outside images. A pretty big bellied man. And I think, did you mention it? He uses nicotine. He is a active nicotine user.
Yeah.
Relatively big abdomen. He has pretty big muscles also. He has clear foraminal stenosis. He probably has a degenerative L5S1 spondylolisthesis, a more or less
significant,
well-preserved remainder of the spine. But there's no pars defect, right?
No pars defect.
So unstable 5-1 joints, the facet fluid sign. Alex, put you on the spot again. Your thoughts?
In the Hounsfield 494. I have summary slides for every section where we have questions.
Oh, good. Yeah. Okay. So why don't you go forward then?
Yeah.
Hounsfield units. Yet, as he goes forward, we use Hounsfield units far more often at Vertebra to determine bone health as an indirect measure of bone health. And go forward, Neil. Sorry, I didn't.
No. So that's 94. So now at this point, we can ask you his opinion on what else.
So what would you do? Any thoughts?
Yeah, this is an interesting case. So first, if I see facets like this, I usually don't look whether there is a pars defect, because usually it can't be. Either you have a past defect or you have got these osteoarthritis of the joints. And this is a really severe case of degen facet joint osteoarthritis. I would go for anterior. I would do an ALIF to restore as much lordosis as I can. And then I would add a posterior MIS. I've seen some scar. I don't want to fall into big troubles. You have to do bilateral direct decompression if you do a TLIF. And everything is then on a small implant. So I would do an ALIF in a very obese patient. I would hate myself for choosing so, but I think in the end is a high amount of forces on L5S1, and with a big cage and a good angle like 15, maybe 20 degrees, and elevating L5. Adding posterior construct will make it stable. This is my suggestion, and I would don't fall in trouble with the scars in the foramen for doing direct decompression.
What do you think, Neil? Should we grant Dr. Mameghani his wish?
Sure. Let's do
Okay,
it.
we're granting your wish. Blink, blink.
Blink, blink. So here, he got a ALIF at an outside surgery center, and this is his intraop images. Really good cage placement, three screws.
Let me ask Dr. Mameghani how he would have. So you want to do it, and by the way, Dr. Yusuf Sharivar suggested for the first case also ALIF and then MIS screws posteriorly. So that's the first case with the degenerative spondee 4-5.
You know, this is like like Julius. Julius is from Bochum, from a trauma surgery, and he used the unstable degen term. When I see facets like this, I don't trust them. You know, if you've got nice intact osseous joints without any gap, without any fluid in it, you can trust on posterior elements. But here, it's like a B fracture, when I may say this because I come from trauma department in Hanover, when I say, you can't rely. I would never do a standalone ALIF in facet joints like these. There's too little support from posterior. Usually we looking for anterior support if we do a posterior construct, and in this case I would do an anterior with a posterior support.
You're like the Oracle. So yep, exactly. Intraoperatively, the cage was good indirect decompression of the foramen, and 5 weeks later, patients started having leg pain. And they got images again, and these are the x-rays at 2 months post-op. And if you zoom in, here's a sacral promontory fracture, and kind of hardware starting to fall apart. So summary again, gentleman presented to us, to the outside hospital, got the ALIF, 3 weeks later, fell apart. So what do we do now?
You had predicted this, Alex. How are you going to get out of this now? You would have not gotten into this because you would have put screws in posteriorly right away. You would have treated it like a flexion distraction, like a B injury. So you foresaw the troubles. But what would you do now? So the anterior column is failing. There's a collapse. Alex, are you there? Dr. Mameghani? You may have lost him. He's here. Alex, what would you do now? So the anterior sacrum is broken. Your trauma background from Hanover, from Professor Kritik, is called upon. I can't hear you right now. Lost your audio. So just in summary, the patient had an ALIF done in an outside hospital. So you're logged in under 2 names, and apparently there'll be a default into audio. Now we can hear you.
Sorry about this. I'm looking for a solution. I will try to fix it.
So Amir, we'll go to you until we hear back. Alex, speak up whenever you're back on. Amir, so we have sacral fractures like 5 weeks. The patient has worse leg pain now and back pain than before. He had an ALIF done. He did not have the posterior fusion surgery. the posterior fixation done that Dr. Mameghani suggested. Your thoughts on this?
I definitely agree that it needs stabilization. I think you could argue, depending on the bone quality, I think you mentioned that this person's a smoker, how much you're going to need, but I would at very least come from the back 5-1 with pelvic fixation as well to really make sure that, and with the question of going up to L4 if the L5 fixation was not sufficient.
So that's a visionary standpoint. And when you do ALIFs, you do a fair number of ALIFs. What cage materials do you use? Is there a preference? This was a big plastic cage, a PEEK device with, I don't know what graft was used inside there, but what do you use?
I typically use titanium. I will still use BMP. I think that it's one of our few on-label uses, and that's just how I was trained. But I think the titanium ingrowth potential is much higher than PEEK. I've seen allograft as well. I think that's a very viable option, but I like a titanium cage with the integrated screws similar to this, but different material.
Got it. Alex, are you live again? Well,
the one
Yes,
thing.
can you, I don't know whether you can hear me.
Yeah, now we can hear you. Can you hear us?
Okay.
Can you see us? Okay. Great. So we need a trauma surgeon and spine surgeon. The patient now has a coronal plane sacral fracture. It has collapsed. He has poor bone stock. He has worse leg pain. Now he actually has a worse spondy than he had before. So what do we do now?
Yeah. So it is spinal pelvic fixation. I would not rely on staying on L5, going to L4 to have a better lever arm is necessary. I think you have to go from anterior again. You don't want to do this in an obese patient in a revision surgery. So it is all posterior for me. An open surgery going to L4, I think I will not manage to go in from posterior for an interbody. Would be in a lateral, maybe an OLIF, something like this in a skilled hand. It's not easy, but at least I would go from L4 to the ilium, and if you present me a solution going to L3, I will say yes, it's okay to go to L3 as well.
All right.
Staying on L5 means you put all the risk on a bone that is in the center of the trouble. It is too risky for me.
Fair enough. Okay, Neil, what happened?
So this patient was brought back. The one thing that I picked up here and should be doing, and I don't present here, is a CT scan. So this patient did not get a CT scan before going back to the operating room. So these are all the images that he had before he was taken back. And then this is what was done at the outside hospital, where they did unilateral left-sided screws, and they intraoperatively found right-sided pedicle fractures at L5, so they were not able to instrument that. I present this as well, and this will become more relevant when this patient presents to us in terms of incision. You can see the opening for incision going from down here all the way to L2 almost, and just placement of unilateral screws here. So he got the unilateral screws, and this is his post-op imaging.
So I want to point out to everybody, as you're scrolling through this, check out that right pedicle at L5. Dr. Mameghani is very insightful. So the right pedicle at L5 had fractured now. He has some gas in his SI joints also, but we don't know what that means necessarily. He's displaced his anterior sacrum. The anterior sacral fixation is loose. He has this bizarre L5 fracture on the right. Is this going to work, Alex? So he'd had a laminectomy done, as you can see, by the previous surgeon, and he had these cortical screws put in. So is this going to work? Is this sufficient or not?
Yeah, if you accept bed rest for several months with all these complications, it probably will work. But if you ask me whether it's the best way we can offer these poor poorly, and the suffering patient, I would say surgery has got some advantages, but with risks.
So this is one of those cases. I see a lot of surgeons doing cortical screws as if we can't put pedicle screws in anymore. And I was just surprised why this patient did not have an attempt, at least at a pedicle screw. And you'll show us, I don't want to preempt your talk, but you'll show us how cortical screws perform mechanically as well as clinically. I did not also understand why these screws were chosen when the incision actually went from L1 literally to S1. So that kind of didn't make sense. It was MIS in name only, but the incision was way longer than anything we would normally see. You can see the retractors. So let's go forwards, Neil. So the saga continues.
Yeah. So he presented to us. So again, just in summary wise, 2 months ago got the ALF, 3 weeks ago had pain, 2 weeks ago got the cortical screws, got the CT scan now, and then because of the pedicle fracture, continuing pain and a new left-sided foot drop, or at least some weakness in the dorsiflexion EHL aspect. He was presented to us, and we decided to bring him back to the operating room. We removed the non-segmental L5 S1 hardware, the cortical screws, which were loose, so they came out just with a coker. We again placed standard pedicle screws at L5 and S1, and then connected the pelvis. So this is our intraop Zine CT. This is the only kind of image I have intraop. So I don't have more formal images, but you can see what we did there. And his incision was not made any bigger than what he already had. He tolerated the procedure really well, didn't have any extra pain. He was walking post-op day 1, and we did do a formal posterior lateral arthrodesis as well. And he was able to go home post-op day 2. He did have some left side EHL and dorsiflexion weakness. He was working with physical therapy. He walked 200 steps with a walker, and he's going to come in for a staple removal and exam thereafter.
So we did posterior fixation, just what you said, and I think Amir said it, but we didn't listen to you. We stopped at L5. We did very large bore screws that are nearly bicortical into L5, and we used them to kind of pull back L5, and we went into the pelvis. We did a very extensive posterolateral arthrodesis into the iliac crest. Didn't do an SI fusion though. So too early to say anything. The patient's still within this 3-month follow-up, but any thoughts if you want to go back to that CT?
Yeah, this is an exceptional good post-op image. I think if you spare to fuse another motion segment, it's good. But Jens, I remember SSF TV on YouTube like 8 years ago or 9 years ago about sacral fractures, and Professor Chapman was recommending long constructs going to L4 in case of sacral fractures. Okay, when you have got a dissociative injury, I know, but I kept this in mind, and in cases like this, I would go still to L4 a little bit differently to your solution, but of course, if it works, you have done the smarter.
Well taken, and again, we were actually prepared to do that, but I was, because of the L5 fracture, I was actually very pleased with getting a very solid bite there, but we'd prepared for the optionality. This was actually the initial plan almost, but I changed that to L5, but we'll see.
We compressed the pedicle fracture as well.
We actually compressed the pedicle fracture, and we over drilled it and got a very nice compression effect. I think we used the largest screws I felt comfortable with, 7.5s or 8.5s, but a terrific bite. So far, so good, but I will send you an email with a follow-up x-ray once he shows up again, but we've not heard from him, and he's hopefully stopped smoking. Thank you, Neil. Next, we have Dr. Brian Anderson, and he's going to show a different slant on care of degenerative lower lumbar problems.
Thank you. So our patient is a 76-year-old male. He's got 7 years of progressive symptoms in his low back and in his lower extremities. They include pain, radiculopathy that's worse than the right, He's got leg heaviness with ambulation, can't walk very far, and he has a little bit of a wide base gait pattern when he does walk. No trauma in the past, no prior spine surgeries, bowel and bladder is normal. On exam, he's obviously sarcopenic, but he's got good muscle strength throughout, and his BMI is moderately low, but in the normal range. His past medical history is significant for prostate cancer. He underwent a prostatectomy with some cyberknife treatments in the past, and also osteopenia. You can see here a standing scoliopian lateral long film X-ray. It does show that he has 21-degree levoscoliosis or dextroscoliosis from 11 to 4. He does have accentuated thoracic kyphosis. He's got a positive SVA, and he has a TI-LL mismatch. These are some neutral flexion and extension lumbar radiographs showing multi-level degenerative disc disease, spondylodic changes, and then a very subtle L4-L5 dynamic spondylolisthesis. It's a grade 1. Here we have a CT imaging of the lumbar spine demonstrating a sagittal, a coronal, and then axial cuts, just showing us with greater detail that degenerative disc disease, a grade 1 L4-L5 spondylolisthesis with some maintained disc space, and then he does have a lateral listhesis at L3-L4 and L4-L5, and very large facets at L4-L5 and L5-S1. Here's an MRI, T1 weighted sagittal and axial cuts, showing this forameter, honestly, not terrible, maybe mild to moderate stenosis throughout, but he does have severe central stenosis at L3-L4 and L4-L5 with those hypertrophic facets and some facet fluid at L4-L5. So in summary, this is a 76-year-old gentleman, low back pain, lower extremity radiculopathy, certainly neurogenic claudication, which probably is his biggest complaint. He's sarcopenic, and he also has osteopenia. Measured on DEXA, it's osteopenia, but when we look at the CT Hounsfield units, it's pretty severe osteoporosis, actually, between 60 and 80, depending upon where you measure. He has this dextroscoliosis with alignment concerns, and then he has central stenosis at 2 levels. He has a 1-level spondy, and then he has these L3 to L5 lateral listhesis. This is where we can consider some treatment options. Given his poor bone quality, you could consider conservative management, maybe get his muscle stronger and work on his bone quality. You could opt to just decompress this gentleman to help out with his neurogenic claudication. Consider maybe stabilizing his spondylolisthesis at L4-L5 with an intralaminar device. Or you can be much more aggressive, and you could do maybe some lateral interbody fusions to restore some foraminal height at those severely desiccated levels. Do a fusion to correct his scoliotic curve, and then decompress him to rid him of this central stenosis.
So if you can go back to him, this is a very nice summary. So Alex, this is something we see unbelievable amounts of patients of. We'll have roughly 25, 30 patients at a clinic, and I'm pretty sure that 5 to 10 patients will come with similar constellations, degenerative scoliosis, a pan-lumbar degenerative process, and a host of medical problems here. Sarcopenia, which we're increasingly realizing is so important. Of course, osteopenia, osteoporosis. He had actually osteoporosis, right?
So on the DEXA scan, this is interesting because of our paper, but on the DEXA scan, he had a normal spine, and then at the hip, he was osteopenic. However, on the CT Hounsfield units, he was severely osteoporotic, between 60 and 80 on the Hounsfield units for his spine.
And Dr. Anderson and some of his colleagues are doing a very nice paper on osteoporosis and a variety of negative predictive factors. It's kind of cool. And one of the big insights, you want to repeat what you just said about diagnostic modalities?
Yeah, so we've done a systematic review and meta-analysis of the literature, and especially for distal junctional kyphosis and failure. And we're finding that studies that include DEXA scans and Hounsfield units, there's really no significant difference with patients that actually have a good postoperative outcome versus those that have a distal junctional kyphosis with regard to DEXA scans. There's no difference. However, Hounsfield units, we're finding a significant change. So patients are with poor Hounsfield units are actually having poor outcomes, those with DEXA.
I thought that's a very important insight. So Alex, again, the common thing in severe stenosis at 2 levels, pretty significant atherosclerosis in the front also, has had radiation treatment, has had prostate cancer. Any thoughts? What do you want to do? This guy can't walk anymore. Nice man, miserable, bad back. You give him the minimalist treatment? Do you give him a maximalist treatment? Where do you come in?
Yeah. Before I answer your question, I have another question for you because of the Hounsfield units and CAT scan. When I discuss with our radiologists about using QCT in Switzerland, in Europe, I don't have anybody who is able or willing to listen to me. I know that you in the US, you're using Hounsfield units a lot, but they are not so validated. How do you live with a QCT or Hounsfield units without validation? Because this is what my radiologists tell me.
So I'll go first, but Brian and several of his colleagues have looked at that actually. So the validation is actually getting better and better. The gold standard, to be clear, at this point in time is still the DEXA scan, but especially a DEXA scan of the spine is frequently prone towards over-representing the spine measurements because of osteophytes and spondylophytes and sclerosis. A CT scan in our PAC system is totally integrated nowadays where we can measure it with an ROI tool. And that's actually far more sensitive and appropriate, at least as a general stratification effort. So between osteoporosis, and I'll ask Brian to comment on the numbers values that he has seen, because again, he's just literally gone through the world literature, and maybe he can answer the question of is it validated or not. But as a risk stratification tool, which is actually very time sensitive, that's another paper that's coming out in the near future by one of our former fellows. That's become a standard of care. And the main reference I quote is Paul Anderson, my former fellowship director in JBJS, I think it was in 2021. And it basically shows very convincingly that CT, not even quantitative CT, is an extremely helpful triaging tool. So Brian, your thoughts?
Yeah, so DEXA scan has been validated in the past, and it's been researched a lot more, but it's encumbered due to just how the study is conducted, and if you have aortic calcifications, if you have significant spondylotic changes with these large osteophytes, it can really increase your T-score, and so make it look like you actually have pretty good bone quality, when actually if you're trying to consider the intervertebral body bone quality, it's not giving you a good assessment of that. And so therefore we use the different areas of the body as well, the hip, the forearm, the elbow, to try to assess the patient's global bone quality. But if you use just a CT, and it has been validated, however, in smaller studies and more recently, you can focus on specific vertebral levels, and it's been standardized to look at L3, you look at it on the sagittal, and then also axial, multiple cuts, and you can average those numbers together and get a very definitive bone quality at that true level.
So to the core question, Dr. Mameghani, Professor Mameghani asked, is this validated now? How validated are the use of Hounsfield units in clinical care?
Recently, in the last 5 years, validation has been done to some degree, but it just hasn't been around in big enough studies. I think there are studies out there that say that yes, this does work, even with routine, not using the quantitative CT protocols that he's discussing.
So just last Monday, we had a research meeting in the afternoon. They're very popular, but the key finding there was that actually Hounsfield units in a macro scale with over 1,000 patients, I think, were more specific to complications than the use of DEXA scans. So that was, I think, a pretty important finding. Okay, Alex, back to the case at hand. We don't have an answer either, but it's clearly becoming far more relevant for us in North America, at least. That goes for our Canadian friends also. So what would you do? Guy has a bad spine, a rotten spine, degenerative scoliosis, stenosis, really bad stenosis, actually 3, 4, 4, 5, can't get around, is miserable. What are you going to do?
Yeah, I would try to do only decompression. If I look to the segments, to the motion segments, yes, the morphologic change is there, but I hope that a plain, a simple approach like decompression only helps this old man to bring him back into an acceptable, better quality of life. When I start with fusion, I'm opening Pandora's box probably, and I end up in a T10 pelvis situation. And for this sarcopenic patient in this age, this will be too much. And I know what I'm talking about. I will show you some pictures later where just I started with fusion down below, thinking I was smart. So in this talk, I would just go for decompression only.
All right, show us the scoliosis one more time quickly. Do you have an AP scoliosis film? I thought I saw one in the beginning. Yeah. Do you have an, yeah, here. So this is degenerative scoli, and the number, the curve was, I think, 21 degrees, T11 to L4, something like that. And you see this typical osteopenic skeleton with sclerotic end plates, thinned cortices, stuff like that. You see the seeds. So, okay, go forward. Show them what we did in the interest of time, because Dr. Pierre is chomping at the bits. He has his case to show. So we actually agreed with you. We did not want to fuse him, and this was not a well patient. Brian, what did we do?
we did not fuse him due to the issues that we discussed, but we did do the decompression from L3 to L5, and given the dynamic spondylolisthesis at L4, L5, we placed an interlaminar stabilization device to stop the anterior posterior motion at that joint and relieve him of that pain. The surgery was otherwise uncomplicated, took about 2 hours. And then here's his post-operative radiographs that were taken in office. He was seen at the 6-week mark, however, he's 3 months post-op at this point. He says that his legs feel great now. He's actually walking 45 minutes a day with resolution of his neurogenic claudication, and he's riding a bike for 20 minutes a day as well. So we can certainly argue about devices, but we clearly felt a fusion was not compatible with his general wellness, and it would have been a major physiologic insult. And we wanted to help him with his neurogenic claudication. Any thoughts on what we did here? Was this device necessary or not? This is something or something similar that you would use in Europe?
Yeah, we see these ISDs a lot in private practice. I've never seen one performed in a public hospital so far, but we have had some RCTs, multi-center studies. I think it was from Bernard Meyer, who spoke 2 weeks ago. He participated in the Coflex trial, and the results were not bad. So I think nobody may argue against this. If you have done a 5-level ISD, I would comment a little bit differently, but in monosegmental, it's okay for me.
So patient actually was very happy. I mean, you see the functional parts. I think his ODI was actually substantially improved. I forgot what it was now, Brian, but it was, I mean, incremental, like well below, beyond 20 points improvements. And the physical component score of our PROMIS score, everything was very good. He was very happy, actually. I was very reluctant, and I have been reluctant to do this in scoliosis patients, but it's actually technically not straightforward. And I have more anxiety putting these devices in on a patient than putting a pedicle screw in, I must say. But the devil's in the detail, but so far so good. And again, we tell patients there's a 15% failure rate within 5 years, and loosening or fracturing is possible. But when we put these in, we've refined some of the tools to not have to bang too much. And so far so good, but we agree a big fusion would be inappropriate, and doing something less invasive in this case means stabilization. By the way, Dr. Randy Davis, great to have you, as I said. We will have a session. I'll invite Paul Anderson maybe to show us and talk, and we'll have Alex Mameghani there for sure also, how to use Hounsfield units and where they stand now relative to DEXA scans in the future. Great suggestion, how to do Hounsfield unit measurements. Last case before we go to our visiting professor, Cliff Pierre, research fellow, great guy.
Yes,
What do you got?
good morning. Again, thanks, Dr. Mameghani, for joining us and accepting the invitation for STED. I have a case of a 45-year-old female who presented with progressive severe low back pain and radiating leg pain with some associated numbness, right greater than left. She denies any bladder or bowel dysfunction, had conservative management. She does have a history of prior lumbar surgery, about 2 to 3 years prior to presenting to our clinic. She had a midline sparing bilateral laminotomies as well as bilateral discectomy by a surgeon at an outside institution. This is her motor exam, intact functionally. This is her functional assessments, ODI accordingly. And then this is her prior treatment modalities with respect to pain management and PT. These are her dynamic X-ray imaging, neutral flexion and extension films, shows that there is no motion. At 5.1, there is a bit of a mild retrolisthesis at 5.1. Going through an MRI, lumbar spine, axial and sagittal imaging, T2. And again, we note the severe disc degeneration at 5.1. with a small paracentral disc osteophyte at that level as well on the left side. This is a CT myelogram. Again, axial and sagittal views. Of note, the retrolisthesis at 5.1 again, and some impingement.
By the way, a great case of conjoint nerve roots.
Yes. And
so, yeah.
again, we have a summary again, 45-year-old female, prior lumbar surgery, has symptomatic disc degeneration, mechanically stable, resistant to non-operative care. What would be some considerations?
And a great summary there. Go back one slide if you will. So, Alex, this is again an everyday case. There are no curveballs here. This is a professional. She has been on pain meds, was willing to get off of opiates. She's not in the best physical shape. She's not terrible. She is willing to amend. Okay, so we'll go to Dr. Abdul Jabbar. So this is a common case. Amir, what would you do? I mean, we'll see several patients like this in clinic later today.
Yeah, I think this is a challenging case. Obviously, you need to get to know these patients well, and I think, and her, just to revisit the clinical history, her main complaint is back pain.
Primary complaint is back pain. When doing activities, especially bending over, she does have some leg pain, right greater than left, but her primary complaint is axial back pain.
Yeah, I try to summarize their pain ratio.
Yeah.
I hope I did that in here, but by memory, it's something like 60-40, 70-30 back pain, leg
Yes.
pain, but leg pain is a component.
Yes.
I think this would be the kind of case that, again, I think not everybody is a good candidate and you really have to know them well, but I would consider a disc arthroplasty as one of her options. A revision decompression, I don't know, is going to offer her a whole bunch of improvement, but, then we were also looking at fusion.
Okay.
But again, I think that these are challenging decisions for someone who is, in the situation with a degenerative disc with a prior decompression.
Gotcha.
From a general standpoint, I don't know what you use. I tell patients when they get a discectomy, this discectomy is done in an outside facility,
Yes.
but I tell them 13% plus rate of either recurrent disc herniation or post-discectomy collapse requiring a re-intervention surgically within 5 years. That's
Yep.
from the SPORT trial. So I still use that number. Do you use a similar number, or what do you caution patients?
Yeah, I mean, I think that, within 5 years, that 10 to 15% is kind of a ballpark range that I typically tell them.
Yeah. So, and in terms of just as a general sketch, what prompts you in a patient like this to go in favor of a fusion versus a disc replacement?
So, sorry, getting my audio on. I think that the main thing is that patients really have to be very understanding of the kind of technology and the disease process. I think if people don't have a really good understanding of expectations, and obviously across the board, making sure there's no psychiatric component to the pain, or that's something that screening is done ahead of time, but that goes without saying. But again, I think the age, activity level, and patients that have had previous discectomy and collapse tend to do pretty well versus someone that has a primary degenerative disease and back pain. I think I would shy away from. Any
prior abdominal surgeries, would that shy you away from doing one approach versus the other?
I think that's important. Anyone that you're considering for a lumbar disc arthroplasty, I would have see the approach surgeon ahead of time. Oftentimes they're okay with doing a anterior approach in the setting of prior abdominal surgery.
I just can't hear. I can't hear anything.
Unless it's something like retroperitoneal radiation, or something that's very low, like a gyne procedure where they're doing a sling in that area. That's something that I think would be a contraindication.
Gotcha. And what about facet arthropathy? You can see a glimpse here, and Cliff put a very nice composite together before, but she has some facet arthritis in there. Is that a real problem? Yeah, if you go through that CT again, I thought that was very evocative.
Yeah, I think it's something that in my practice, I've done very few of these. I would shy away from the facet arthropathy, but it's really a kind of a gray scale where how much is too much. I've seen some of the practitioners, our TBI friends, are a little bit more aggressive in terms of what they'll accept. But again, that's something that is really a gradation scale, because everybody has some sort of facet arthropathy. But if it's very advanced, then that's something where they're going to continue to have pain there if you don't fuse that segment.
I actually routinely get a SPECT scan, a technetium 99 scan, to look for inordinate arthropathies or curveballs. Like in her case, this is a good stop here, SI joint arthropathy, and she did not light up there. Yeah, and the retrolisthesis, is that a concern, Amir?
Yeah, I think that it's very kind of subtle retrolisthesis, and you would want to make sure that there's no dynamic instability. If there were, from what I remember from the imaging placed earlier, this is not a dynamically unstable, but that would be a contraindication.
Correct. Yeah, she remains mechanically stable, so no dynamic issues there.
So let's drum roll forwards. And
so these are our intraoperative films. We had an approach surgeon, one of our vascular surgeons. We do quite a number of these cases with. Very experienced hands. She did have history of prior 2 C-sections, but this was no issue for her. And here we opted to do a lumbar disc arthroplasty. And these are her immediate follow-up films 6 weeks after, and then again, films remained unchanged about a year and after. So she's about 13, 14 months post-operatively, and these are her post-operative functional performance assessments.
So this is one of those insightful things. Thanks for putting that up. Yep. Because we don't have the latest one. We don't have the 24 one.
It wasn't in the the documentation.
The latest one has actually gone down dramatically. It's like 16 or so. The pain interference score. This is like within about a year. So pain interference score, the lower is the better. Physical function score, the higher is better. So she had actually had an improvement, not dramatic. The latest one was very, very good. She just came back for clinic at the 1.5-year follow-up.
Yes.
And she is subjectively very happy. Yeah, sorry.
Yeah, and then this is just a shameless plug for those who are on that didn't probably didn't get an opportunity to catch us live session last month. Dr. Harvey Smith from Penn had displayed some of his research from his lab with respect to disc arthroplasties, as well as our colleagues from TBI showed the 24-year report with really great results and long-term follow-up for these patients, specifically related to decreased ODI, and they maintained that improved level of decreased ODI and decreased pain scores for these patients. So preserving motion and keeping it intact is really a good thing for these patients.
Yeah, in terms of a bioreactor, Harvey Smith has probably one of the leading concepts of how to repair a disc. I'm not sure that he would be willing to test this patient in that, because that's a very burned out disc.
Yeah.
If you go back one more time, Alex, are you live again? I hear your voice in the back.
Yeah, I'm here. Can you hear me?
Yes, loud and clear. Go forward again to that final film, final x-ray. So we did a disc arthroplasty in this lady with an isolated 5-1 post-discectomy collapse. She's very happy. She leads a normal life pretty much. Is that something you guys consider? Are there a lot of caveats? Where are you in Europe? You started this whole thing. Where are you now?
Yeah, I did my last TDR in 2016, and then I stopped. I haven't done quite a lot, so it's less than 15. I would use an ALIF now, and it is a little bit a question of where you live and what is your environment. If everybody is surrounded, you surround haters of TDRs, it's a little bit difficult for me to recommend a TDR. But it was the indication, and we have happy patients. I remember talks from Ted Jensen, who said in his talk, "Friends don't fuse friends," and it's good. I did it. I left it. We had some troubles with bad implants. We've had this implant file thing here, and TDRs have been among this. So the karma is not so good today. But recently, I recommended a TDR to a young patient in a similar situation. And she went to a second opinion and was convinced to get an ALIF. So I think I will again look for ideal patients, but to be honest, I think I'm not a TDR specialist.
Got it. Great. Thank you for the case presentations, our fellows, all four.
Thank you. Awesome.
And wonderful commentaries in the chat box also. It's a great honor, and I'm highly conflicted to introduce Dr. Alex Tapio Mameghani from Canton Spinal in Switzerland, in Baden. And he has a who's who in terms of his track record in spine surgery. He has crossed paths with Professor Walter Dick, Professor Gab, Christian Krüttig in Hanover, the famous Benny Jeanneret, and Professor Scheren in Switzerland. And he's the head of spine surgery at the Canton Spinal Baden in Switzerland now. He shares a common pathway with mine from Munich. He is also an artist. He is a pianist and a composer. And I love these kind of multi-dimensional talents. And he's going to talk about cortical screws, which, again, we showed a bad case of an application. And he's going to convince us that this is actually a very useful and meaningful clinical addendum. So great to have you here. Thanks for joining us. Sorry for the problems.
Yeah, thank you very much. Yes, it's really a big honor for me to be invited and to talk about this topic, cortical bone trajectory. I'm following your STAT talk since a long time, and this invitation was really a big honor. So my disclosures are a little bit important because I'm a consultant of Medactor and Depresintis. I show some pictures and you can identify some implants. I'm also an orthopedic spine surgeon, a little bit AO spine addicted in the past, where I've met Jens Chapman a decade ago. So let's talk about how we do pedicle screws today. Nobody questions the trajectory. Everybody is familiar with from lateral to medial, from parallel to the end plates. Symmetry is a topic. Everybody wants to present nice post-op images, and if the one screw is there and one screw there, we think, we could do better. But nobody talks about the entry point. Everybody finds his way where he wants to place the first entry point. And let's talk about accuracy, tons of data, and this pedicle screw works in any indication. And when we ask about what is a good screw in the bone, we are looking for long screws. I guess everybody agrees that 30 millimeter S1 screw is a bad choice, and going bicortical, that means a long screw, is good. And the diameter is important as well. It should not be too tiny, should have some space for revision surgery, but the thicker, the higher the diameter is, the better is the insertion torque. But to be honest, most of the screw is in the cancellous bone, and the cancellous bone is the soft bone of the vertebra. And you can have a perfect screw and still it's a bad screw. And sometimes in osteoporotic spine or in the ankylosing spondylitis, you have the feeling of we are putting some screw in butter. And this is about osteoporosis. We've mentioned this before in the discussion. And to be honest, is this really a good screw, regardless of the accuracy, regardless of the post-op image? We see so many failures. And the demographics are really coming. This is an image I've stolen from Jens Chapman's talk about the silver tsunami. We have got drugs, we have good prophylaxis, but the problem of a weak, soft osteoporotic bone will not be solved by medication in the vast majority of our patients. I'm not talking about sarcopenia, I'm not talking about frailty, but these three, when they come together, it's better not to fuse. We've seen the case before. What is our salvage procedure? We are using cement, lots of cement, tons of cement. I'm using like more than 100,000 Swiss francs for cement each year, not for vertebroplasty, but for cement augmentation to save screws in the backbone. I mentioned my average patient is like 75 to 80 years old and is osteoporotic. So this poor patient, and this is an actual view of these cement augmented. You have the same. You're running through the videos so nicely in your talks. This is always the same, and it works. But is this really the best option we have, or is there another trajectory safe and allows to be used in osteoporotic bone with adequate strength and without the use of cement? And yes, there are some folks, and me, I'm among of them, who thinks we can use it. The first talks I've had, I always made this artistic filter about this CAT scan because I didn't want to confuse the audience too early in my talk, because this is a highly unusual screw direction. Today you see it. You've shown this L5 as one case with unilateral bicortical screws, but I was surprised when I came into this field and I was introduced to this technique. I could not imagine that this is working, and I asked, why is this working? So this is a case, slip vertebra L45. Maybe you can see the date. It was from 2016. She was 61 years old, has had a radiculopathy. You don't have to ask why she had this radiculopathy, but she was not operated. She went to conservative treatment, everything with it, until she came back and said, no, the leg pain is getting worse and I have more back pain. And on the new images, you've seen two new vertebral fractures. One is healed, the upper one, and the lower one is still with edema, sclerosis. We have cleft on CAT scan. I don't show you, but this is a subacute fracture. And now we have not the slip vertebra as the only diagnosis. We have slip vertebra plus osteoporosis plus vertebral compression fracture. Would you now suggest you do the same procedure like you have done without knowing that she will have compression fractures? And this is a question. And so we have this CBT, this cortical bone trajectory, and we have some differences. And I just run through some slides and tell you the quintessence of the screw, because we placed the screw where the bone is the hardest. When Jens asked why did the surgeon choose cortical bone trajectory, maybe because the surgeon thought there the bone is harder than in the cancellous body. And a screw where osteoporosis is a less huge problem. This is a posterior element. It is known since 2 decades. 2009, there was the landmark paper, and it has always had this old-fashioned, yes, it's not innovative, it's a difficult technique, lots of failures. Some CBT have not been CBT, but ruining the pars, ruining the facet, ruining the pedicle. So it was something for the skilled surgeon. And today the company switched to another term. They say it's MC, it's midline cortical. And midline cortical sounds a little bit more neutral. And I have chosen cortical bone trajectory so you know what I'm talking about and not to use some new branding. But it's you make the cut in the midline. Jens, you mentioned you are a posterior surgeon. You love the posterior approach. The question is, how long is your incision and what do you have to expose? Like in midline cortical, this is what you have to expose because the screwdriver and the trajectory doesn't need to go from this lateral entry point to the medium, because you come from the medium and you're going to the lateral. And in theory, this is a trajectory that allows a lesser invasive procedure. So when you come to the entry point, this is the hardest thing. When you want to do it freehand, it's really something have to look where you start. Remember, the innervation comes from the lateral, the blood supply of the facet joint comes from lateral, and if you using the traditional trajectory entry point in the mid of the TP where it enters to the pedicle, you are denervating the joint, especially the upper joint. You are cutting a little bit of the blood supply when you are the bipolar coagulation. If you're using it extensively, you know what I'm talking about. Today I'm looking for cautious use of bipolar in this region. But the CBT screw, the entry point is here. It's on the lamina. It's under the TP entry into the pedicle, and it's in the line of the facet joint. And so when you expose less of the spine, you cut less of the nerve vessels and you cut less of the dorsal branch, and maybe this helps to prevent some of the adjacent segment disease, but this is not proven. So this is one of the cases, 81-year-old male patient. I did some laminectomy years ago. No, not laminectomy, posterior decompression. The lamina is there, but the spinous process has broken. And the patient has had now a re-stenosis. It's such an awful thing, a re-stenosis, or to be honest, everybody may say Dr. Mameghani did a bad decompression, but there have been several years in between. So my plan here was to decompress and to perform a fusion as 4S1, because I didn't want that the patient comes back 1 year later with a re-stenosis. But this was just my thought. I did it navigated, 3D navigated with my usual system, and I navigate many screws. Mainly, my goal is to navigate every screw. And you see nicely on the sagittal down left that the upper part of the pedicle. The Hounsfield uses, when I may use this term, the Hounsfield units here are low, and in the lower end plate region, the Hounsfield units are high. This is the sclerosis, the osteochondrosis, and in a traditional trajectory, the vast majority of the screw would be in these bad cancerous bone. This is L4. This is the situation L5, navigated. You see you're crossing the pedicle. There's not much space to the spinal canal. It's completely different to this huge L5 pedicle that we have seen in the cases in the beginning. And you see the ascending and the diverging trajectory of L5 and S1 as well. And so here you can see S1 starts a lot more medial, it's diverging, and you see where the screw tip is. It's pretty bicortical. So 2 years later, L4S1 was fused. I didn't do an interbody, too much scars. I was a little bit too cautious. I was frightened to go interbody, but it healed posterolateral. And then the patient came back later, 4 years after the CBT. It was one of my first, navigated with a ASD. So ASD still exists. It's not solved by CBT, by midline cortical screws. And now the patient was 85 years old. I had to do some else. I did lengthen it. So I went up 2 levels. I put an interbody, and maybe not the smartest move, I went to L2. And now the patient came back very early, like 3 months with a PJK. Still PJK exists. So the biology, the situation of sacral disbalance is not solved by this trajectory in my point of view, and I lengthened it. In thoracic, I went traditional technique, and you can see here now, this was L2 where a CBT screw has been, and I was able to put traditional pedicle screws here because they were loosened, and I didn't want to keep L2 without screws for better biomechanics. I mounted some Z rods, and this is what I've done navigated. On the market, there are 3D printed drill guides, and these drill guides come from a Swiss company. I live in Switzerland, I work in Switzerland, so it's just clear that once any spine surgeon in Switzerland gets in contact with this platform, and you have jugs, and these jugs, I show it here into the camera, they are 3D printed. You send a CAT scan there to the company, and they create the surface rendering, and they create this drill guide for each vertebra. It's unique, it's patient matched, and we have this patient matched technology in different parts of orthopedic surgery, like hip, like knee arthroplasty, shoulder, and again, the Swiss company made some drill guides for the spine. So finding the entry point is so easy. You just put these drill guides on a nicely prepared vertebra, and you put it on it, and it guides you to the entry point. And you only have to drill, and it's really nice because the planning is pre-operatively done, performed, and extensively. I don't know whether you do the planning of every screw in your system. Do you really place any screw on the computer preoperatively and find it intraoperative? I don't do this in a standard TLIF. I examine the pictures, but I don't plan it. With CBT, I changed my planning philosophy a lot. I was looking a lot more to CAT scans, to renderings, to the model, and I really recommend to go back to these models in the beginning when you think you could start with this technology and find the perfect entry through for CBT. So this is the planning tool. I'm just running through it. You can see this is the vertebra from the patient, volume rendering. You can rotate it, you can flip, you can do anything with this, and then you can even put in some screws. Here you can see screw head. You can make the vertebra semi-visible, and you really are able to change any angle, any this is a planning tool I found very attractive. And as you do before the surgery, preoperatively, you don't have to use extensively lots of X-ray. Whether you have a O-arm or a CT, or whether you do it with X-ray, when you have this jig, this drill guide, you just have to make the localization where you are, that you're at the correct level, and the rest is performed without X-ray. And this is really nice because the team and you as a surgeon get a lot of less collateral X-ray exposure. So from the biomechanics, let's have a look. Here on the left side, the traditional, on the right side, the cortical bone trajectory. And even when the screw is shorter, like 25 millimeters for CBT and 35 millimeters for the TT, even the diameter is different. You see that the Hounsfield units of the CBT screws, where the CBT screw is a lot higher. And now, since I use this CBT, I look for Hounsfield units. So I was asking you in this audience a little bit what is validated. I use Hounsfield units since years because in CBT everything is on Hounsfield units. Is it white? Is it gray? Is it dark? It matters. And in my personal experience, I can't live without Hounsfield. So this is the 4 points of contact. You want to start in the lower part of the pedicle, near the pars. You want to pass the medial part of the pedicle. You want to pass the lateral part of the region where the pedicle goes into the body, and you want to end up in number 4 under the end plate. These 4 points of contact here, the vertebra has its most dense bone, the densest bone. And the densest bone is the best bone for the screw. I think this is universally accepted. If you have a loose screw in a butter and you have to rely that this is the upper instrumented vertebra, you will expect cutout immediately. When you make a map, Hounsfield unit on the y-axis and the length of the screw on the x-axis, you find a significant difference between CBT and traditional technique. On the right side, there's some kind of heat map. In the traditional technique, the Hounsfield unit is maximum like 350 and goes down to 100. In CBT, you rise to Hounsfield units like 900. So it's really the strong bone where the screw is. We have in time of climate change, we like this climate, these climate maps. And here again, where is the bone the hardest? In the inferior pedicle, near the pars interarticularis, and on the lateral part of the vertebral body near the pedicle. And I analyzed a lot of these maps, and I think it's really crucial to understand the meaning of the CBT screw. Denser bone, stronger screw, the minimum length should be 35 millimeters. If it's too short, the CBT screw gets bad. This is experience from Matsukawa, but also Santoni in 2009 has talked about this. The insertional torque. So how much force do you have to apply to get the screw in? On the right side, the traditional technique, you see you need double of the force. In several experiments in the lab, they found that the insertional torque ends up like 1 Newton meter in the traditional technique. This is the lower one, but in CBT you have to apply a lot of more force to get the screw in, and this is like double. This is a machine. The machine was drilling the screw into the bone, and the short screw was a lot better. When I may use better, it's different from the scientific view, but I say better. this is the part that the CBT screw is stronger than TT. Long screws, I mentioned, if the screw is too short, like 25 or 30, it's too short, it's a bad screw. The bone screw interface is important too. And I just wanted to mention this landmark paper from Santoni, 2009, means 15 years old. Look, every resident, every fellow should look up the reference list of this paper. It's pure gold. You understand a lot of why people are looking about different solutions, different trajectories. And this is like the Big Bang. Santoni in 2009 created this with Sight AI. Another pioneer is Matsukawa from Japan. Lots of surgeons from Asia, from Asian countries are using CBT, maybe because of the philosophy to go minimally invasive, but not to lose the midline approach. It's a lot of culture influencing the adaptation of technology. In this meta-analysis, you can see on the names of the first authors that the country, we have US-American surgeons using this, but the vast majority comes from Asian countries. And these meta-analyses found, written here or declared in the forest plots, that when you compare CBT to TT, then there's a favor. Some things are statistical significant different, like the operation time, like the blood loss, like the hospital stay. Everything is shorter or less. Even the incision length is, I don't show it here, is significantly shorter, but the outcome is not so overwhelming better if you measure the ODI. So this solution of this lady with the new osteoporosis was, I did a CBT, I did some vertebroplasty, I surely overstuffed this vertebra when I look at it now, but this was my case. I did this. When it comes to obesity, and skin incision is a problem too, and exposure, this is the same situation like your case, big fluids in the joints, L4-5. And what did I do? I did L4-5, L5S1, and I added some SI1 screws. And on the AP view, you see the alignment of the screws is pretty nice. It's pretty convenient because it's in line. So when you look at robotics are using more and more CBT because you can have a less invasive approach. Martin Farm, who has been a guest here too, has some fantastic robotic trajectories and solutions, and robotics will push CBT or midline cortical a little bit. You can print your own jigs, so this is something which is easy to produce, but you need a lot of time and money if you don't want to use the company. But these 3D printers are available. They are certified for medical use. And some surgeons even try to augment these CBT screws, like 1 milliliter of cement, and it works in a cadaver. I have never used it in real life, but it is possible. So this was a short talk. Some recommendations: don't use it tomorrow. Prepare, go to courses, go to the web lab, to the skill lab. Read tons of literature from countries. Maybe you're surprised how often they use it. Study everything, 3D reformats, bone models, sawbone models. And if you choose the first case, you should choose a slip vertebra L4-5. Use navigation if you're skilled navigator. Use drill guides if you're uncertain. You get a lot of help by sales reps. Don't underestimate skiving. Skiving when the instrument slips from the bone due to too strong bone. And please don't try to do it freehand. It can end up in disaster. We will present in Bangkok our experience, our data, and now it's up, and I thank you very much for inviting me. Thank you a lot, and I hope you have now a little bit of sense what CBT is.
That was really cool. Thank you. Very thoughtful, I thought very honest and circumspect. So one question that immediately comes to mind, so I'm gonna not change my technique right now, but I'm fascinated by the opportunities and the expansion of options. And I think that's always very important. Where does CBT come in when we have failed pedicle screws? Is this a good salvage option, and vice versa? If a CBT screw fails in a patient, can we still salvage it with a conventional screw plus minus cement?
So I will say the traditional technique is a good salvage procedure for a failed CBT. I will not use CBT to rescue a failed, loosened TT, traditional technique. So the traditional technique stays is my rescue screw number one. CBT is for the virgin spine, the first surgery, the less invasive approach, a good option. If it comes to revision, lengthening, yes, but going to the instrumented vertebra with the problem, I will switch over to traditional technique.
So a good answer. Young Dr. Patel, I knew he was, I was going to ask the question, but I didn't want to preempt him. He has a burning question for you. Here's Neil.
So for cortical bone trajectory, you have the screw head sitting at the disc space level. So how do you, in order to put interbody spacers or something like that, how do you kind of overcome that? Do you put the spacers in first and then the screws? And reduction, because you can't sink your screw heads as much in terms of reducing spondy. So how do you address those challenges?
Yeah, this is perfect. Perfect question, very good. How is the order? First, you may not resect any bone, otherwise you are lost. Without the bone, you can't navigate. Without the bone, you can't use these jugs. So first, you put in the jugs, your navi, and you burr your holes for the screw. And you're tapping it with 4-5, with 5, with 6 millimeters, tapping drivers, but you don't insert the screws. After you've prepared the canal for the screw, you do all the things you have to do, like inserting the cage, discectomy, whatever you want to do. You can do it bilateral, whatever. Then I use the K-wire, put it into the hole, but you don't have to use the K-wire. Then you put in the screws. And when you have a slip vertebra, you put in the screw in the upper vertebra deeper, and in the other one, in the lower one, less deep, and then you can do the reduction as well. Think when you place a TT, a traditional screw, too deep in L5, in a listhesis 4-5, you fall into the same trouble. Yeah, you can't reduce because the screw head is too low, to anterior. In CBT, you can reduce the slip vertebra, you can restore lordosis the same as in traditional technique. The question number one is, do you have to reduce the slip? But that's another question.
Then he has a follow-up question.
What are your thoughts on double stuffing a pedicle with a second cortical screw with a traditional trajectory screw for extra purchase? Have you done that? And safety, efficacy, etc.
So pedicle.
Yeah, I've read a lot about double pedicle screw. I've never done this. I've had no need to do this. Double rod, yes, but double screw. I mean, my patient's 75-year-old. The pedicle diameter in L4 is not so big. In L5, yes, maybe it's possible. I have no experience with it. I think it's some kind of experimental, but the thought is good.
So this is a good lecture. And before we say goodbye, we had a question that I forgot to ask before from Dr. Andrew Youngheim, and that was, do you remember that case with that ALIF that failed? His question was, with an ALIF where you put a lot of force on that, does it help if you have an anterior plate in addition to those interference screws? So anterior plating to supplement anterior fixation, putting less force on your posterior hardware. What are your thoughts on that?
Yeah, it's like in the ACDF, huh? In the trauma case, you put in a cage or a bone crest and then the plate, and then you pray a little bit that the interior only approach is sufficient stable. In the ALIF, I switched from these devices with the integrated screws to a plate. Now I do a plate, but the plate is undersized. This is not a huge plate. If you compare the size of the plate in cervical spine with the size of the available plates in the lumbar spine, you think you are going down to some kind of mini plates or bonsai plates. It's too tiny, not thick, not wide. The rotatory stability is not overwhelming, so I don't trust the plate. I do stand alone with a titanium printed cage and a plate, but not in a case that we have seen. When the posterior complex is too weak, the plate will not be the one I rely on.
I agree. Just for the audience, there is a U.S. manufacturer. There may be more, but I know of a company called Royal Oak Medical. They've actually been here and they've shown their jig. They have a similar throwaway plastic jig. It's actually a disposable plastic. It'll probably still create microplastics, but it's kind of an interesting biomaterial. But they have a similar jig that you showed for Medacta. So the thought is out there, and there are other companies, but I thought that was compelling. This is a great talk. Thank you so much, Alex. Wonderful.
Thank you for having me. It was an honor and it was a pleasure.
And hope we'll have you here so you can show us the CBT in the future, and we'll have a CBD oil package for the post-operative recovery for your CBT patients. So that was a lame joke. Thank you. Take care.
Thank you very much.